Welcome, everybody. See, can we move to the next slide? So as people are filtering in, please put in the chat your name, preferred pronouns, organization, and what's your favorite thing about summer. And our fearless leader, Dr. Jung, is out on vacation this week. So I'll be kind of leading the echo. We have Dr. Rampersaud, who will be presenting on SSRIs, and then Dr. Wong will be helping with the case discussion as well. All right, and let's go ahead to the next slide. A couple of announcements. Reminder to please keep your cameras on, particularly during the case discussion. We're wanting to foster a sense of community, and it's really helpful to get to see you all as possible. We know it's during lunch hour, so please feel to free to eat your lunch. I think we're all at this point frequently eating on camera, so no worries about that. And then a reminder, we do record during the didactic part of the presentation. And we have a new announcement. We have an advanced echo that's going to be starting in January 2024. So that'll build off of our prior echoes and going in more in depth on some topics, and then also covering some new topics as well. So stay tuned for additional information about it as we get closer. Okay. And next slide. And we have no one involved in the planning or presentation of this activity has relevant financial disclosures. We are supported by HRSA as well as the California Department of Healthcare Services, Prop 56. And next slide. So I'm shortly going to pass this over to Dr. Rampersaud. Dr. Rampersaud is a child and adolescent psychiatrist at UCSF. He completed his MD and PhD in microbiology and immunology at Columbia University and his psychiatry residency and child and adolescent psychiatry fellowship at UCSF. He has interest in the treatment of mood disorders and the impact of trauma on mental health. And his research focuses on understanding the role of the human gut microbiome in the development of psychiatric disease and biological mechanisms by which early life adversity affects physical and mental health. And we're so excited to have him here today to talk with you all.
Great, thanks so much. We'll jump in. I'm going to try my best not to be super long-winded, and Dr. Schumacher will keep me on time, I hope. So today's topic is all about SSRIs, and so just objectives. Really want to have people be able to come away with being able to talk about very commonly used SSRIs, and think about a little bit also about dosing, be able to think about how we talk to patients about the risks, side effects of SSRIs, and then also talk about the potential benefits. And so hopefully this will prompt a good discussion about maybe how this has come up in your own practice. Next slide. So I put this up to begin with as the first slide, because a lot of our treatments up to date have sort of been built around this idea, excuse me, of the monoamine hypothesis, which suggests that depression and other psychiatric illnesses are sort of a developing out of a deficiency of things like serotonin. And while that may be partially true, it's not the full story, but it has guided the development of most of our drugs, including SSRIs. And so SSRIs, or selective serotonin reuptake inhibitors, are the most commonly used class of antidepressants. And I just want to make this note that only a few of the SSRIs have FDA approved indications in pediatric populations, but the lack of an FDA approval here is not because they don't work or because there's something negative, but in fact is really just the lack of sufficient studies that have tested them in randomized controlled trials for a specific pediatric indication. And a big question that often comes up, and one that I ask myself regularly, is one better than another? And we'll bring it up again in a minute, but there really is no evidence to suggest that one is better than another in children or adults. And so we'll talk a little bit about how you might try to apply a framework to sort of have some rational selection of the antidepressant that you choose for the patient that you're seeing in front of you, but there is no superiority of one over another when making a choice here. And in the back, you can sort of see the idea was that these SSRIs block presynaptic serotonin reuptake. It sort of lives in the synapse for a longer period of time and was thought to sort of normalize that serotonin monoamine depletion that is potentially related to depression. Although we're learning more and more now that SSRIs have lots of different interesting effects, and that's actually part of some of the work that we're doing right now is to understand how they work. And in addition to depression, these SSRIs are also used for anxiety symptoms, OCD, so they have lots of different uses. And we'll talk a little bit about the sort of anxiety and depression kind of split there. So next slide. And then next one. And then one more. So when we think about treating, we think about three phases. There's the acute phase, the continuation phase, and the maintenance phase. And the acute phase is where we're sort of initiating treatment with somebody, and we're hoping to get full symptom reduction and remission. Continuation, we're sort of past that point. We've reached a point where people have been treated and we've gotten symptoms down and controlled and we've achieved remission. And we want to kind of keep that person in a stable place where we avoid relapses. And then maintenance, avoiding recurrences and new episodes. And then on the left-hand side, you see here just sort of some definitions when we're talking about antidepressants. A response means the person has had no symptoms or a significant reduction in symptoms for at least 2 weeks. Remission, period of at least 2 weeks, but less than 2 months, with no or very few symptoms. And then recovery, an absence of significant symptoms for at least 2 months. People often relapse, and that is the nature of depression, at least, and anxiety disorders, where there's an episode of an anxiety or a major depression during a period of remission. And then recurrence is sort of a development of an entirely full-blown new episode of depression. Next slide. And so the first thing we often talk about, and you've probably experienced this when you call the phone line, is we always want to think about medical mimics, right? And so we want to ensure that we're dealing with sort of a primary psychiatric issue and not an issue related to an underlying medical disorder. And so here's just a list of things that you might think about when you're trying to rule out an anxiety that's due to a medical illness. And so I won't go through the whole list, but you can see lots of different things, including hypothyroidism, eating disorders underlined there. So you can see that's an important one to be thinking about, electrolyte imbalances. And then a big thing, especially in our sort of adolescent population, to be thinking about is substances. So things like caffeine, but stimulants, and then also be thinking about illicit substances. Next slide. And so same thing for depression, right? There are lots of different medical conditions that can sort of present themselves as a primary psychiatric issues. And so important things to do, right? We want to get some basic laboratory tests, including thyroid functioning test, CBC, electrolytes, blood glucose, BUN, liver function tests. depending on your level of suspicion for the symptoms for a depression that is related to a underlying medical issue. So, this is where your clinical judgment comes into mind. But if you have any concern, that doesn't hurt to sort of get a routine laboratory test. Some of our kids who maybe are sort of medically less healthy or maybe are taking medications, you might want to be thinking about antihypertensives, benzos. For some of our older kids, be thinking about oral contraceptives, anticonvulsants, or another big one that maybe could sort of masquerade as a primary psychiatric issues, and diuretics. The other thing that I don't think is maybe listed on here, but I'm not seeing it now, but be thinking about our kids who are maybe having issues with obesity or high BMI, right? There might be some connection there with their elevated BMI or obesity and the presentation of depressive symptoms. And we want to be thinking about that when we see these kids. And so we're really thinking here about sort of the diagnostic piece. Am I looking at a primary psychiatric issue, or is there something else that I could be sort of managing to help with the symptoms that this person might be experiencing? Next slide. So I think we talk a lot about this, especially when you call the phone line, but I think screens and tools can be extremely helpful in helping guide you and in terms of making a decision about whether or not you want to start a medication for somebody. And so for me, if I think about my own practice, it kind of helps take the guesswork out of things. Clinical judgment is always key, but scales can be really, really helpful. And so in terms of thinking about, assessing for an underlying anxiety that maybe is contributing to symptoms that you're seeing in your office, be thinking about using the GAD-7 or the SCARED. The GAD-7 is a short version, and then SCARED is a self-report, right? Child, if they're old enough, and then parent will fill out that form, and it can give you lots of great information. And again, depending on the kid and the age, I think getting parent input can be hugely, hugely helpful in understanding what's happening. In terms of depression, right? You all, I'm sure, have used these things, but the PHQ-2, which is a sort of short screener, and the PHQ-9, which gives you a little bit more information about what might be happening for a kid, and then the short mood and feelings questionnaire. And then the RCAD is another one that can assess both anxiety and depression. And I think these can really, again, be really useful in terms of deciding those next steps of, do I just sort of watch and wait? Do I start a medication? Maybe we start with therapy first. I think it really can help guide you in terms of what you want to do. The RCADS is maybe not the most useful and helpful in terms of your own time, because it is a 47 item questionnaire. But if you want to get a detailed information or you have time, it could be potentially useful. And again, like I said, there are cutoff scores, and it can really serve as a guideline to help you make a decision about what you'd like to do in terms of medication. Oh, next slide. So general guidelines. I kind of said all of this already, but SSRI efficacy, they tend to be similar. There's no indication from any of the studies that we've seen that one is better than another. So how do you make a choice? Well, I think it can be based on past response history. So if you end up with a kid who shows up and says, I've had X, Y, or Z before, it was helpful, but I came off of it, not a bad idea to sort of go with that. You can think about side effect profiles or coexisting medical conditions. The other thing that's not on here is family history, right? So if I have a mom or a dad who says, yeah, I took Zoloft and it was just like the most amazing thing for me, I really felt fantastic afterwards, you might think about that as a starting point. And so I harp on this a little bit because sometimes we wish that there was a little bit more of a hard and fast set of rules. But I think this is where a little bit of trial and error and getting a little bit more information can potentially be helpful. We'll talk a little bit about rational drug choice in a minute, but just want to bring it up here. The other big thing, this is for you and for the patient, right? It's 3 to 6 weeks between reaching a therapeutic dose and getting some symptom improvement. although you can see some remission or some change in symptoms by week 4. But again, we tend to tell people, give it 4 to 6 weeks before we sort of say, yes, this has been helpful, or no, it hasn't. And remember, we're making dose adjustments all along the way, right? And so just, I think a little bit of patience sometimes is necessary. We have to guide our families to sort of say, listen, let's give it a little bit more time. Let's see how things are going. If no improvements after 8 weeks and an adequate dose, and we can talk a little bit more about what an adequate dose means, you can either switch to another antidepressant or augment with another agent, depending on how you feel and whether or not the person has trialed a number of things previously. And then with SSRIs in younger children, it has been shown that there is greater benefit in anxiety disorders than depression. That doesn't mean that it doesn't work for depression, but just notably, anxiety disorders are sort of somewhat easier to treat with SSRIs and tend to have a better effect. Next slide. So we do have some studies that can help us make decisions. And I think, I'm not going to go through each of the trials because I think it's sort of neither here nor there, nor is going to be super helpful. But I think the big thing here, and the TADS was the big one, demonstrated that a combination of therapy plus medication really was the best, most effective combination. In clinical practice, sometimes therapy is not totally accessible. We can't get to it. We can't get to it right away. But at the end of the day, I think when we're talking to our patients, we really want to emphasize the fact that a combination of therapy and meds can be really helpful. And I think one thing that I've often said to people is, sometimes that depression is really, really significant, that you need a little bit of medications that kind of help you make use of the therapy. And essentially all of these other studies kind of say the same thing, that these medications work really the best with therapy. And predictors of improvement include things like, getting kids at a younger age into therapy along with meds if necessary, can be particularly helpful. Next slide. And then here is just a demonstration of the anxiety studies. The CAM study is sort of the biggest study, and here's the punchline. Really, CBT plus, for the biggest study, the CAM study, CBT plus sertraline was the most effective, and then CBT alone and sertraline alone, Zoloft, were equivalent to each other. So main point is SSRIs can be helpful for anxiety as well. And again, combined with therapy, this is really sort of the best bang for your buck. Next slide. And then one more. Great. So how do we make a choice? And this is where that conversation about screening tools can be particularly helpful. And so when we're using those screening tools, right, we can categorize people into mild, moderate, or severe. And here you have, the PHQ-9, I think could be a very useful tool because you score it up. And so a 5 to 9 is considered mild, 10 to 19 moderate, and 20 to 27 severe. And I think that, again, this can be very helpful because it can help you make an initial decision about what you want to do. So again, clinical judgment kind of is above all of this, but the PHQ-9s and these structured assessments can really help you make decisions. So let's advance 2 slides. One more. There we go. So how do we get started? And this is where that stratification of mild versus moderate to severe helps you to make a decision. And so if someone has a mild depression, in that PHQ-9 of 5 to 9, you could sort of end up in this place where you're kind of doing an active monitoring for 6 to 8 weeks. Set and monitor goals, wellness goals. So making sure people say, let's work on your eating, let's work on your sleep, let's work on your exercise. We want to make sure we collaborate with families, and then also do a bit of safety planning in case something does come up. But again, in this sort of mild area, sometimes the best thing that we can do is say, let's watch and wait, but let's be clear about what it is that we're looking at. And I think tracking things over time, especially things like sleep, irritability, engagement, can actually be really, really helpful. But then moderate to severe, if you're into that moderate to severe kind of category, you can be thinking about immediate treatment. And this is where we think about, do I do psychotherapy, and evidence-based psychotherapy, or do I do a medication, or do a combination of both? So we can jump to the next slide. And so we talked a little bit about evidence-based MDD therapy. So that includes things like CBT, IPT, and I see the question in the chat. So we'll make sure that we get to that question at the end because it's a good one. Next slide. Keep going. Sorry. Let's pass this completely. And one more. And again, keep going. Oh, did we go backwards or did I have duplicate slides? Keep going. Okay, so when do we prescribe? Because we said, okay, if we're in this mild phase, we kind of sort of make decisions. We're kind of thinking a little bit together about what to do, maybe watching and waiting. Moderate, severe, we're thinking about maybe we're going to start a medication for somebody. So when do we prescribe? Well, uncomplicated mild anxiety or depression that you watch for 6 weeks and then progress to a moderate phase. I often use the second point, significant impairment. I often tell people, you only have to do, kids, you only have to do 3 things. You have to eat, you have to go to school, and you have to take care of your body. And if any of those things are not being done, then that to me is a great indication that we should be starting something. Failed or partial response to therapy and active support. So maybe this person was moderate, but we said, well, they're still going to school, they're still doing things. Let's try to get them hooked up into therapy. And by some magic, they got hooked up to therapy fairly quickly, and they got into it and they started doing it, but they didn't quite progress. Maybe some symptoms improved, but they're still feeling particularly depressed. They're still in that moderate phase. Then you might think about adding on a medication. Again, parent and patient both agree that medication is necessary. They feel like it's important, and they've been educated on risks and benefits. Also, you all know your patients best. So is this a patient or a family where I could give them something and parents can monitor, or I have the capacity and the practice to monitor, and I know this patient is going to be compliant or will be able to communicate with me. This is a part where it's about your comfort level, saying, I feel good about this family. I feel like I can give them something and it would totally work. And then, again, like I said, can you consult and collaborate? I think this is really key, especially in a busy practice. Can we work with the families and others to make sure that we are able to sort of, deploy this treatment in a significant way? Next slide. We already talked about this, so we can go to the next slide. So here's just a table, and this will be available of sort of the medications and then the forms that they're available in. I think this is important. You can see most of these are actually now available in liquid, especially for the younger kids who can't quite swallow pills. It's something to think about. Do I have a liquid form of this that I could give? Although I often will try to get kids to learn how to swallow with like M&Ms and Skittles and things at home with their parents, because they eventually have to learn how to take a pill. And so you can see here the FDA indications on the far right-hand side. Again, I want to emphasize, just because it has an FDA indication doesn't mean its other things don't work. Next slide. So a little bit about rational drug selection. So you have a list here. I think the main points here are Prozac is really great because it does have a long half-life. If you have a concern about a patient who can or can't, can adhere to a medication, this can be helpful because a missed dose is not such a big deal. We tend to think about Prozac for some of the kids who maybe have a little bit of like a neurovegetative kind of depression. So the kids who are a little bit slowed down, maybe oversleeping, don't have much energy. Prozac can give them a little bit of an energy boost potentially. Zoloft, sertraline tends to be a little bit more sedating potentially. And so it can be good for maybe kids who have a little bit more of an anxious flavor of depression. Lexapro and Celexa tend to be more neutral. And the one thing there that I think can be helpful, the dose range is a little bit smaller, right? The increments by which you can go up, but Celexa and Lexapro can be helpful because they have less drug interactions. And so it's something that I've often used with kids who maybe are on complicated drug regimens, because I know it's not going to cause any problems. Next slide. So before starting, we want to educate people. We want to get consent from the guardian, but then also have buy-in from the youth. We want to have a safety plan, and then have a schedule of like how we're going to follow up. Next slide. Keep going. Okay, so visits. In the first month, you kind of want to be able to monitor weekly. That doesn't necessarily have to be an in-person visit. It can be sort of a phone check-in, but we want to be sort of monitoring in a significant way. And I think, getting parents or caregivers involved will be really important. You start low and then increase every 2 weeks if you're not seeing a side effect. And I would say, every 4 to 6 weeks, really, rather than 2 weeks, depending on the situation. In that second month, then you can sort of go to monitoring every other week. And then in that third month, maybe, monthly. And again, clinical judgment sort of kind of comes into play here. Next slide. This is a list of side effects and ways to manage them. I'm not going to go through them, but a lot of these things are typically self-resolving. Many things don't, will sort of just disappear. And like the GI distress is a big one. And I often tell people, give it a couple weeks, give it 1 or 2 weeks, and let's see if it disappears. If it's mild. Next slide. One of the things you want to watch out for is if you're on a SSRI with another medication that can be potentially inducing, lots of serotonin release. Want to think about serotonin syndrome. And so this typically occurs within 24 hours. You get this sort of hyperreactivity, things like other serotonin agonists can cause problems. And you see this constellation of symptoms. This is not a common thing, but if we're getting up to super high doses or we're combining with other serotonin agonists, we want to make sure we let people know about the potential for this. Next slide. And so just want to quickly talk about the black box warning. This was issued in 2004. There was some increased incidence of suicidal ideation or self-injurious behavior, although there was no actual increase in suicides in these studies. But we do tell people about this. We want to sort of guide people and let them know this is a possibility. And it can be highest in the risk in the first 9 days of treatment. Let's go to the next slide. And so for parents, I'll leave this here, I won't read it, but this is a little bit of a, kind of a guidance in terms of what to say about activation, which is a sort of increased energy, kind of restlessness. I call it sort of inch in your pants kind of feeling that can happen with SSRI initiation. But just to remember, I put this chart at the bottom just to remind people that it really is safe and it is effective. Next slide. Let's skip this. Next slide. And then this is just a slide. You can have this available. These are predictors of suicidality within, with the initiation of SSRI treatment. And really the big thing here is like depression, previous suicidality, previous self-harm, all the things that we're asking about when we're making decisions to prescribe. These are all things that are going to potentially increase the risk, but we would be monitoring for things like this anyway, because previous suicidality, you can see, has like a really big odds ratio here. So let's move forward. Next slide. Keep going. Great. So, yeah, there we go. So I just want to make quickly just one thing about activation. So it's, again, this like difficult, uncomfortable feeling that happens when you start with the SSRI. It happens pretty quickly. You can assess whether the person is adhering. You could decrease the dose or switch to some kind of to another SSRI or stop altogether. But again, we want to ask our patients and our families about this particular symptom. And if it's mild, we don't necessarily have to discontinue right away, but it's something to watch for. Next slide. And then hit one more. So there we go, perfect. So we always want to be thinking about behavioral activation versus bipolar switching. And I think the couple of things that come up, there's a temporal nature to this. So behavioral activation, the activation for the SSRI kind of happens in the beginning, in days to weeks after the dose is increased, whereas bipolar switching can happen later in treatment. And then it's the mood piece, right? You're thinking about like whether or not this kid has had a bipolar issue, the mood has increased or changed, right? Whereas with activation, there's still sort of the same kind of mood. We can keep going. And so we'll leave this available to you so you can see it. Let's go to the next slide because I have like 1 second. And sometimes when we're switching, we want to switch from one to another. And I would encourage you to call us because this is really an art and not a science. And so you can start the new SSRI at a lower dose while also lowering the current SSRI. Or if you have Prozac, which has a long half-life, you can discontinue it and then start the new SSRI at a lower or equivalent dose. You can go to the next slide. And I put this in here because this has sometimes been helpful. This is the half-life on the left-hand side and then the dose equivalence on the right-hand side. And it can sometimes help me make a decision in terms of switching. How do I want to make my cross taper where I'm going up on one, but going down on the other? Next slide. And then some people can experience discontinuation symptoms. And so you can see them listed here. It's not the most common, but it's more common when you've got kids who are on an SSRI for a long time or have an abrupt stop to their medication. And less likely with fluoxetine because it does have such a long half-life, it sort of just kind of trickles out of your system. Next slide. And these are just a list of symptoms that can occur after discontinuation. It sort of feels like a sort of uncomfortable flu, but it's not life-threatening. Next slide. We recommend treatment lasts 6 to 12 months. And then we can have a conversation about whether or not you want to discontinue with close follow-up to see if you can sort of persist. But the name of the game here is often kids will happen to be on it for an extended period of time. Next slide. And that's it. So I sort of breezed through. There are lots of great questions, and hopefully I'll have an opportunity to talk about some of those questions in the next half.
I have a question if there's some patient education handouts on the UCSF CAP website regarding side effects, like when we first start someone on an SSRI, like something we can give them that, like watch out for these symptoms.
Yeah, that's a great question. I'm not actually.
I'm looking it up because I thought we had an SSRI handout, but that may not be for families. That may be for.
One I especially like is the kind of ACAP, the Child Psychiatry Organization, has a kind of parent medication guide. I'll put that in the chat. Hang on.
And we do have the SSRI tip sheet, but it doesn't. It gives you a little bit about side effects and the timeline of the side effects. So if you go on the I'll put the link in the in the chat. That'll be easier than trying to direct you with bad directions to the right.
And with the parent medication guides, there's one for depression, and then there's also one for anxiety disorders. And there's both for the anxiety disorders one, there's both an English version and a Spanish version. But I like these guides because they kind of talk some about like what the recommendations are for treatment and why those are the recommendation. And then it goes through kind of common concerns families have about these medications.